Today we're going to talk about a case in prostate cancer that illustrates a lot of the current thinking in how to manage this disease as it evolves over time. So this is a 67-year-old man with metastatic castration-sensitive prostate cancer. So here we have a 67-year-old active man presenting with intermittent back pain and loss of appetite, who has an unremarkable past medical history and a family history of cardiac disease, with his father having a myocardial infarction, a history of dementia, but no history of prostate cancer or any other cancers in the family. He presents to a physician and is found to have on digital rectal exam, is found to have an asymmetric enlarged prostate, but is otherwise unremarkable on clinical exam. He undergoes a prostate biopsy with transrectal ultrasound, which reveals him to have a T2 prostate adenocarcinoma, grade group 3. And a bone scan done to work this up reveals 3 spinal lesions at T10, L2, L3, and 1 in the left iliac crest. An abdominal and pelvic CT scan show no other sign of metastatic disease, and PSA, unsurprisingly, is elevated at 24.9 nanograms per ml. So then he's presented and counseled on various treatment options for his disease, for at this point, which would be considered metastatic. So there are a lot of options to consider in a patient like this. One of the issues in the current era, in 2020, 2021, of course, is do we do anything besides standard hormonal therapy? And it's quite interesting that for many decades, standard hormonal therapy was the first choice of treatment. And I would say that treatment was done in a sort of expectant fashion, where we would start with standard hormonal therapy. When the disease got worse, then we would bring in further therapies. But there are a lot of studies that we can discuss now that allow us to bring in additional therapies earlier in the clinical course that lead to enhanced clinical benefit. So he most likely was counseled around the use of an AR-targeted drug such as abiraterone or enzalutamide, both of which have significant level 1 evidence favoring their use in the castration-sensitive metastatic prostate cancer patient, as does docetaxel, which is approved for use in the castration-sensitive metastatic setting, based essentially on the CHARTED study that was done in the United States and the STAMPEDE study that was done in the United Kingdom. So the patient starts docetaxel plus ADT, and this is initiated at 6 cycles, which he tolerates well, and his PSA declines to 6.2. Now, just a brief point about when I counsel patients. I would say that for most of my patients with high volume disease such as this, with a high PSA such as this, and especially in a healthy patient who's relatively young such as this, I do recommend chemotherapy, although that I do pitch it as not the only choice. The advantage of chemotherapy in this setting is that it's a finite period of treatment. It's actually just 6 cycles of docetaxel, 6 doses of a drug, 6 visits to the clinic, and then that treatment is done. And that compares very favorably from a survival perspective, for example, to the use of abiraterone or enzalutamide in this setting as well. So patients really have a choice. If they want to avoid chemotherapy altogether, they can take enzalutamide or abiraterone, but they are required in that case to take many pills per day. There is ongoing monitoring that is required. And the treatment is somewhat open-ended. It's not done after a period of 16 to 18 weeks like docetaxel is. So oftentimes, given those choices, patients will decide, I'll take the chemotherapy, because if you look forward 16 weeks from now, they will be done with all that treatment. And some people find that favorable. Of course, there are some potential risks from the chemotherapy, such as marrow suppression, that one needs to take carefully into consideration, in particular in your older patients, or maybe patients with prior radiation therapy, or maybe some patients with prior chemotherapy exposure, or other factors that might make chemotherapy a little bit more caution-inducing than an oral therapy.